Telling you must review anatomy, always. You've got to understand structurally what we're talking about and what's the purpose and function of each part of that anatomical place, okay? And so we focused on the pleural space here. What was the pleural space responsible for? What's maintained in that pleural space? What's maintained in the pleural space?
Negative pressure.
Negative pressure. Why does that matter? What is that negative pressure going to do? It keeps, right, because nothing's tying my lungs down, nothing's keeping them open, even during the expiratory phase, except that this pressure that creates a vacuum in there. And if we lose that vacuum, that negative pressure, what will happen?
It's going to collapse.
The lung, in layman's terms, collapses. That's exactly right. Okay, so anything that can disrupt that pleural space can lead to what we discussed the other day. Remember, my trachea was pierced, and Celeste was my right lung. Y'all remember that? What will happen if those pressures are unequalized on one side or the other? The trachea deviates, okay? And we talked about in which direction would the trachea deviate. It's going to deviate away from whichever side has greater pressure. But you have to understand what causes those changes in those pressures, okay? Everybody good so far? All right, so that's just kind of a recap. I'm going to go past these because Mr. Money has done a great job of this. I do want to focus on this for just a minute because we kind of gently touched on hemothorax the other day. Remember I was telling you a hemothorax is just where we have a collection of blood now. Okay, but it doesn't matter if it's in the pleural space or if it's in the abdominal cavities or it's in the brain. What do you worry about when a patient is putting out more drainage than they should be? What do we know is going on? They're actively bleeding. So the bigger concept here is when do we report the amount? So 200 mils, 2 consecutive hours, you've lost approximately a unit of blood. A unit of blood is approximately 450 mils. Okay? When you think about 400 mils over a 4-hour, that's quite a bit of blood, isn't it? And so we need to be thinking about that. Also, if a patient had, let's just forget chest tube, that's called a JP drain in the abdomen. If you're constantly having to empty that JP drain, we know we've got an active bleeding. What if you have a JP drain that you emptied at one time, the next hour you have nothing coming out? Is that normal either? No, there should be a tapering of flow. Okay, there should be some tape. Y'all, what's going on today? Now y'all ain't done this all semester long. Y'all gonna wait till my last day.
No, man, I'm sorry. It's my fault.
Is it your fault?
Yes, ma'am, it's my fault.
Are you taking ownership?
Yes, ma'am.
It's so not like you because you're usually here about 15 minutes before
Right,
class.
it's a rainy day, that's why.
Okay, I can see, okay. And I'm wearing my comfy clothes, so we're gonna roll with it today. All right, where was I? Oh, hemothorax. Okay, so JP drain. So we have a JP drain in, and all of a sudden we have this sudden cessation of drainage. What are we worried about? Clots, because we know hemostasis doesn't happen like that. We don't go from this active drip, 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 drip to nothing. So we worry about clots. Why would a clot be concerning to me, regardless of the type of drain I'm talking about? Okay, let's say a patient has a ventric drain in. It's going to increase pressure, which can cause those particular areas not to get perfused adequately, right? Okay, and as Mr. Money presents on chest tubes, if you've got a chest tube that's not draining, it can actually cause a what, Brianna? We talked about this in clinical yesterday. And where's Jordan? She's like, no, call me. Jordan.
Ma'am.
It's not draining. What are you worried about? What can it cause? Now, this is a pulmonary problem.
So like hemothorax or
What can a hemothorax cause if the chest tube's not draining? Oh. I want her to think.
Okay, wait, say it again.
This is our safe place. We can think here. We're not worried about what people think about us. All right, so you've got a chest tube in. It is not draining. We have a hemothorax. What cardiovascular complication can that lead to?
Oh yeah, cardiac tamponade.
Boom. A cardiac tamponade. You see how we have one system that it's a different system. And yet that collection of fluid that isn't draining and we start to build pressure because we've got increased volume, what does that do to venous return? It decreases, there's only so much room for everything to work together in here, and if I keep increasing volume, whether it's air or mass, eventually it's going to impede the vena cava's ability to return volume to the heart. I know this ain't y'all got the end of the semester, look at you.
Yes, ma'am. I
Because
do.
normally I'd be really stern about that. We'll roll with it one more time. Okay, after that we'll lock the door. All right. You can see where if this is not draining appropriately, that it could actually cause so much volume to be in this chest cavity that it impedes venous return to the heart, and we end up with a cardiac tamponade. Okay, I need you to be able to link those things together. So as a nurse, again, not going to take up time to the chest tube part, but I need you to be thinking critically. It's not about what kind of drain it is, it's about the function of it. And do I understand when I need to make phone calls? Do I understand when I need to investigate things? And do I understand when things are going as they should be? Okay? All right. One last thing. Look at the position of it. Pierce. I promise I won't drink it, but can I borrow that for a second? Okay. So Pierce has a straw in his drink. Okay, so let's say he didn't, but I don't think he bought this, but let's just say he paid, $10 at Starbucks for this, okay? 8, whatever it is, I don't know. Oh, you got the Dunkin' Donuts. I might need that, but it's a better visual.
It's probably better coffee as well.
All right, so here we go. Just curious. $7?
Oh, no, it was like 4.
Oh, okay. My budget. All right, so, but she paid $4 for this, so by golly, she wants every morsel of it. Right? Okay. So she's drinking, her straw's here. Eventually, her fluid becomes trapped here as she's drinking through to the bottom of it, right? Okay, y'all see what I'm talking about? Okay, well, let's apply that here. The chest tube's here, and my fluid's down here. If the chest tube's located higher than where the fluid is it going to evacuate it completely?
No.
Okay, so then all of a sudden we turn the patient and we look at our chest tube, like, where'd that come from? All we do is we reposition our patient, and now it's able to drain that content out. So it's a weird word, but dumping. We call that dumping. We don't panic about that. Okay, if I see a momentary increase in my drainage that's related to we just changed the position of the patient, we just stood them up, whatever it may be, and we watch it, and it's not continuous. It's not like we've started something to bleed, okay? That doesn't mean I'm not going to report it. Okay, as a nurse, I'm going to keep my patient safe, so I'm going to report it because I don't know for sure that that's what it's related to, but I'm going to use that critical thinking. I'm going to say the patient was laying on their right side, we hadn't had a lot of drainage out, I moved them over, I stood them up, whatever, and had a dumping of 100 mils, whatever it may be. I've had no further drainage since, just wanted to make you aware. Okay, now I've done my job, I've reported it, but I also use my critical thinking to know that this is nothing we'll panic about. We just had that last little bit of $4 coffee, and I want to make sure I move my straw in the right place to get it all out. Okay? All right. So, where are we at? Yep. Okay, this is where I want to pick up today. So, the trach, the new trach, not a trach the patient has in for years to come, okay? But your new trach and all ET tubes have these certain features on them that we need to maintain positive pressure ventilation. So, I've got these balloons. You see these things here? We call them cuffs. And they'll be on the end of your new trach tubes as well. What do you think the purpose of that cuff is? Okay, sort of. There you go, Josh. When you positive pressure ventilate somebody, in other words, you're blowing air into them, it's going to meet some resistance, isn't it? It's not a negative pressure ventilation system we're maintaining anymore. We're not pulling things in. We're forcing air in. It would be very easy to understand then how that air can come right back out. I need it to dwell. I need that oxygen to dwell. So we inflate this cuff that will help prevent that from coming right back out in the absence of a negative pressure maintenance system. Okay? So the purpose of the cuff is to help make sure that that dwells and doesn't come right back out. Now, there's some little things about that cuff that we'll talk about in just a few minutes, okay? Some We have to exercise certain caution with looking for certain things, how much do we actually inflate that, etc. But your new trachs and your ET tubes, all ET tubes will have a cuff that's inflated. So you can't see that because this part of the ET tube is typically down inside your patient. So I can't visualize it. But I've got this little thing called a pilot balloon, a little pigtail. Have y'all seen those of you who've been in clinical already? They're kind of spongy. They should be intact because it's kind of an indirect visualization of the integrity of your cuff. If it's flat as a flitter, whatever a flitter is, if it's flat like that, then you have a cuff that's probably leaking. But you probably already detected that before because your patient starts making these sounds. It sounds like they're burping. The only way for you and I to talk or to make a sound is for air to come back up the trachea past the vocal cords. Well, when we got this cuff here, aren't we preventing that? So your patient should not be able to verbalize anything to you or make any sounds that sound like a burp. Okay, and if you start hearing that, or you can actually make out something that they're trying to say to you, you have a cuff leak. Your cuff's not adequately inflated. Okay? Your patient should not be able to speak to you when a cuff is inflated. Now, please don't go assessing that. This is not part of your standard assessment. You don't go to an intubated patient and say, Ms. Watkins, can you speak to me? Because Ms. Watkins is going to be like, don't you know I can? What's wrong? They're going to be scared. You know, that's not an assessment finding, okay? You know, it's not something you're going to go look for. Does that make sense? Okay. I'm trying to give it a better example, but that's the best one I can give you, okay? So we don't go assess the ability to speak. That's the standard of care, it should be there. Okay, so the purpose of the cuff is to help maintain that positive pressure, and the pilot balloon kind of gives you an idea of it. Now your trach usually doesn't have the little pilot balloon always on it, okay? Don't work for it. The markings on this ET tube are radio opaque, meaning I can kind of see that. I can see where my cuff is. That's really important. The centimeters at the teeth. Now, some institutions say lip, some say teeth. NCLEX is not going to ask you which one is it. You just need to be consistent with what you choose. Some say lip because not everybody has teeth. Whatever. Doesn't matter. Just be consistent. Okay? So if we're looking at the teeth or the gum line, look and see how many centimeters at the teeth or lip or whatever your tube is at on assessment. Why do I need to keep assessing that? That's right, because it can be displaced, either too far down or too far out. We're going to talk about complications of what would happen if it goes too far down, and obviously you know what happens if it comes too far out. 22 to 24 centimeters is your ballpark. Okay, 22 to 24 centimeters is your ballpark, which is where most people need their ET tubes to be. And what does ET stand for? Endotracheal. So make sure you know anatomically where we're going with this. We're going down the trachea with this one. Whereas your orogastric or your nasogastric tube goes down which hole? Which part of the body? The esophagus on into the stomach. Okay? Make sure you understand your distinct differences there. This is, you can read this, guys, okay? But a lot of it's common sense. The mouth's a big wide open cavity, so it's not hard to access to intubate a patient, okay? But then you can think of some disadvantages. It does make it hard to perform oral care. How often do we have to do oral care? Every 4 hours minimum. We'll talk about why in a little bit. Every 4 hours minimum, oral care must be done. They have these nice little fancy kits today. You guys have no idea. So I'm gonna tell you. Cool little kids, you put your little spongy thing in there, you connect it to your little yonker, and you're like, hey, you know, I'm not gonna tell you what that was like. But oral care every 4 hours. Okay? So then you can see where a tube in the way can actually impede the ability to clean that oral cavity every 4 hours like it needs to be. It's also easier for your patient to accidentally extubate themselves. I had a gentleman, I'll never forget as long as I live, he worked that tongue until he flipped that thing back around his mouth. Right? Yay. Still taped, but curl up in his mouth. You know, that's not working. Okay? Don't do that. We can cause trauma to the vocal cords. That's, you know, so there's lots of different things, and you can see where some advantages versus, for people with a pretty bad gag reflex, they're going to need to be pretty well sedated, okay? Because this is definitely going to get that thing going. Whereas your nasotracheal, which you're not going to see as often, But we do see it where people are nasally intubated. Remember, it's still going down the trachea. It reminds me of a lady I encountered with her mask. And I thought, it's hard because your lay population really doesn't understand things. But she wore it over her mouth only because her answer to me was, well, I don't breathe through my nose. You do. But you don't make fun of people, okay? You contemplate before you respond. A lot of education was needed there. You do breathe through your nose. She didn't understand, okay? She thought it went someplace all by itself. No, I don't, she really didn't. Okay, I said, no, what's gonna come over here too. So people don't always understand that, but nasal intubation, you can right down the trachea tube. It requires a smaller tube. One of the advantages of it is it's not as easy for the patient to accidentally extubate themselves. And once it's in place, it's easier to tolerate because it doesn't seem to stimulate that gag reflex. Okay. However, as you can imagine, it can increase ICP. So we don't usually use this for people with any type of head injury, any history of sinus surgery or some problems. Okay. And you can also imagine how it could be more likely to tear up a mucosa as opposed to the other. Okay. And yet it doesn't impede oral care, whatever. So what are we going to need to intubate? Well, first of all, you're not going to be the one doing that, but you need to get all the supplies ready, okay? So we'll need our bag valve mask. We're going to need the right size ET tube. The standard, most adults take a 7 or a 7.5 ET tube, okay? A 7 or a 7.5 ET tube is what most adults will require. We're going to need a stylet, which is a little piece of like a metal wire that we put down inside the ET tube to give it some more rigidity. Kind of like a feeding tube has that little wire in it. You know what I'm talking about? Okay, this just provides it to not be so plastic. It provides it some density, some less, so when we put it down, it's not all curling over, bending over on itself. We're going to need to have the ventilator ready. So RT's got to be in there and have that vent ready if we're about to intubate a patient, okay? So we've got to look at those teeth. Do they have that one little snaggle tooth hanging on by a thread? It's probably not going to survive this. So we need to have that documented very carefully, okay, and communicate that to the provider in case they want to, let's just get this thing out. Because they could aspirate. Let's just make sure. We're going to want to make sure that if they have false teeth again, those are out, okay? Probably would help your patient have some degree of sedation, if possible. That's not always possible, okay? Sometimes we just got to get this thing in and be done with it. But if possible, some level of sedation, because this is scary for them, okay? Suction equipment, that should always be standard in your unit anyway. All right. The provider will determine if they want a curved blade, these are curved blades, or a straight blade. That's a provider specific thing. And if anesthesia puts it down, they'll have this fancy little gizmo called a glidoscope, which is really cool because what happens when, I told you I taught ACLS for 10 years, when you intubate the trachea, as you're going down with your ET tube towards the vocal cords, which is what you're aiming for, you're going to go straight between the two vocal cords, you lose visualization at that point because now all of a sudden your ET tube's blocking your view and you're blind from that point forward. The glidoscope gives them the ability to look on a screen through like an ultrasound type image that they know exactly where they're going. Okay, so those are really cool devices.
Do you see like the camera?
Yeah.
Okay, yeah, I
really
seen
cool.
one.
You saw it, didn't you?
Yes, ma'am.
Yeah, cool. Okay, really neat things. All right, so they've got 30 seconds per attempt. So they will bag, they'll attempt 30 seconds, and then somebody's a mind keeper on that and make sure that we know we're not into it a minute and a half later. We haven't oxygenated patient at all for a minute and a half. So we'll abort, bag, and reattempt. Okay? 30 seconds. Hold your breath for 30 seconds and see how you feel. Not right now, I don't want you to pass out. Okay? See how you feel. It's a long time when you're watching the clock. You're like, really? So, immediately after they have gotten in place, they're going to pull the stylet out. They're going to inflate the cuff and they're going to bag their patient. And what am I looking for on inspection? Symmetrical rise and fall. If I don't see symmetrical rise and fall, and instead I see the belly looking a little distended, we've got to get that thing right back out. We cannot afford to be putting all this air in the belly. What's going to happen if we do that? What risks what risk are we increasing when we put all this, cause gastric distension? Vomiting. They're gonna aspirate. What if I only see the right lung insufflating and the left side's not rising to that same degree? We went down too far and we intubated the right main stem bronchus. So we deflate the cuff, we back it up, we reinflate our cuff, and we re-bag the patient. We're hoping this time we have symmetrical rise and fall. Now that's past inspection. What's the next step in assessment? Auscultation. So we're listening for bilateral breath sounds. Then we order a stat chest x-ray. And what we're looking for in the chest x-ray is that the end of the ET tube is 2 centimeters above the carina. What's the carina? Bifurcation. That's where your ET tube should sit. Then it's secured, attached to the vent, and we monitor our patient's response from there. Okay? Now, we talked about gastric intubation, we talked about right main stem bronchus, we talked about vomiting and aspiration. Trauma. Those blades, whether they choose the old-fashioned metal blades or they use the nice little plastic ones we have today, they can still cause trauma to the mucosa. Intubating the trachea itself can cause trauma to the trachea. Okay, so we want to be careful of that. Oryngospasm. Y'all ever accidentally inhaled a little bit of vinegar or mustard? Yeah, that's called a bronchospasm. Don't panic, it's going to pass. Okay, but that's a bronchospasm, and it's where your larynx closes up on you. And it's scary. It's terrifying. But that we can cause that because the vocal cords don't want to be manipulated. Hypoxemia, if we're not successful, if we have prolonged intubation attempts, and whenever you have a hypoxic patient, based on Module A, what can happen to your rhythm? Ventricular dysrhythmias, VTAC, VFib, okay? So we're gonna monitor our patient for any of these nasty outcomes that can happen, and this takes place really, really, really fast. Okay, we're not staring at them for an hour. We're looking at this in minutes. Are we where we need to be? Okay. Now, I'm just going to focus on this for a minute. At what point do we go from having an endotracheal tube to a trach in intensive care? Based on research and a lot of data that's been collected through the decades, at 21 days, the benefits of an ET tube no longer outweigh the risks associated with it. And at this point, it is safer for us to put in a trach. Okay? Because they're already in the OR, they go ahead and put a PEG in. But that's not a standard of care. It's just because why would we take the patient for 2 surgical procedures when we can do it at one time? Why do you think they would put a PEG in as opposed to an NG tube or a feeding tube? Okay, but what's the key to the fact that it's right there in the stomach? What are we minimizing in terms of risks? Aspiration. That's right, aspiration. Because if you're not keeping an eye on your feeding tube or your NG tube that we've converted to feedings now, could it not be coming up the esophagus ever so lightly? And doesn't that increase the risk of aspiration? Okay, a PEG reduces some of that risk. In time, not immediately with a trach, a patient will be able to eat and talk. The key is here is when we've gone from a cuffed trach to a cuffless trach. That's when that can happen, okay? But we're focusing on a cuff right now. All right. Moving, like I said, this is all reminders of trachs. All right, regardless of your trach or your ET tube, cuff pressure we talked about, and that's how important that is, that we can maintain the integrity of that cuff so that we're making sure that that positive pressure ventilation dwells, okay? They'll do what they call, you're not going to be doing this, okay? Your RT department's going to be monitoring your pressures on your cuff. Your responsibility is to report if you hear all of a sudden those burping type sounds or it sounds like a patient's trying to vocalize something, okay? I'm going to get to this when I get to ventilator settings, okay? All of this is saying this in a nutshell. We know that, and you're not going to be doing this either, okay? But I want you to understand what we're talking about here. We want that trach cuff or that ET tube cuff inflated to the point that it maintains positive pressure ventilation, but what I don't want is it so snug up against the mucosa that it causes tissue necrosis of the trachea. That's a bad day, right? So we want, they'll do what they call a minimal air leak test, which is where they know this much is required to maintain the integrity of this cuff. any more than this, and we're gonna be snug up against that mucosa. But going along with this same concept, I want you to think about why we do things like oral care, maintain the head of the bed at 30 degrees, make sure that we have checked gastric residual for our feedings, is because everything we're doing here is to prevent ventilator-acquired pneumonia. VAP. Ventilator-acquired pneumonia is considered a nosocomial or hospital-acquired condition. And it all goes back to what we were talking about with this cuff. It's not so snug up against the mucosa that nothing's going to get past it. So if your patient were to vomit, they could aspirate. Those fluids can go past that, so we're going to minimize the possibility of that happening by keeping the head of the bed at 30 degrees at all times. Doesn't that remind you of what we do for a patient with feeding? Same thing, isn't it? So the head of the bed does not get lowered below 30 degrees. We're going to do oral care every 4 hours. Why? What does that have to do with ventilator-acquired pneumonia? Your mouth is nasty, folks. There's some stuff going on there we don't even want to know. I've been a nurse 36 years. I don't want any cultures of my nares. I don't want to know what lives up in there. Been around so much stuff in my career, there's no telling. Ignorance can be bliss. I'm healthy. I'm okay. But with your mouth, your oral cavity has so many pathogens in there. And we know that that cuff isn't going to prevent any of those secretions from draining down and being aspirated. So we now know that if we keep the mouth clean and we use these products that are available to us every 4 hours diligently, we're going to significantly reduce the incidence of ventilator-acquired pneumonia. Okay, so these measures are in place. Check gastric residual. I was telling my students one group, it was humiliating to me as a nurse that this was the level of care that the patient had been receiving. She's a really nice physician. She has one of the most pleasant personalities, but she went in there and she's a hands-on doc. So she checks her own residual. She came in there, she pulled back 500 milliliters of gastric residual, and it was going at 22 milliliters an hour. Oh, what does that tell you? Somebody's not been checking GRV, because there's no way to get 500 mils with a 22 mil an hour pump. Okay? That's embarrassing. I'd be humiliated if I was that nurse. For sure. You got to check your GRV. How much, and you'll have a policy in your agency, and go back to your fundamentals. It tells you, at what point, if 500 mils or more, you hold it. Then you contact your provider, right? If you've got more than 200 consecutive 2-hour checks, you got to hold it and you got to call somebody, because we need to either drop that rate, let this pass. Think about the patients who are at risk for decreased gastric motility. Who are they? Who's at risk for decreased gastric motility? One of your primary patients. You're diabetic. They've got gastroparesis. All those nerve endings that feed that system are just like their nerve endings in their feet. They don't function right anymore. And so they're prone to gastroparesis, which means their motility is far, far slower than it should be. So stuff tends to sit in their stomach longer. Okay, and those, you want to critically think through, what can I do to prevent this patient from developing ventilator-acquired pneumonia? Who's at risk and what are they at risk for? Okay. I talked about the tissue trauma. Now, isn't it true that tissue anywhere in my body can be subject to injury in a situation of hypotension? Because that goes back to basic perfusion, right? Like our septic patient, okay? Dehydration, you know that from fundamentals. We've got to have adequate fluid volume status in order for the patient to achieve adequate perfusion. Hypoxemia, if I've got a patient that's, who had the FiO2 85% yesterday? Who was that?
75.
Okay, so that's 75. That's a pretty hypoxic patient is requiring 75% FiO2. Okay? You're elderly. We know that. Okay? Their systems are, quote, retired, end quote. Okay? They are more predisposed. They fought their battles, and their ability to fight more becomes compromised. Steroids, we know, reduce the inflammatory response, and we understand that intrinsically the inflammatory response is there to protect us. Okay? We talked about all this. Now, stabilizing the tube and then repositioning the tube. Okay? RT will come reposition, because we don't want it up against the edge of the mouth forever, do we? We're going to cause tissue necrosis there. Have you seen patients who have NG tubes in for a period of time? What happened to their little nostril? Yeah, you get tissue necrosis there, okay? So we need to be judicious in cleaning that. Blah, blah. Move on. All right, this is a refresher from fundamentals. When you're taking NCLEX, there's always two you're going to eliminate. Which two will we eliminate here?
The advancing.
The advancing, so A and D. We know that's not correct. So we're down to the two that would always get stuck on. Which one's correct? D. Yeah, you don't want to be suctioning for 20 seconds. And you want to use intermittent suction. Why do we use intermittent as opposed to continuous? What's going to happen? What's more likely to happen if I use trauma? Because it can suck up against the mucosa. Okay, if we intermittently do that, we're not going to, that's not going to be as likely to occur. Okay? I think this is one. Okay, I did not address this on purpose because I need you to critically think your way through this one. I gave you the concepts that you need to answer it. Mr. Money, this is one of those that would, if I had a poll everywhere, this is the perfect question. Okay, so I need somebody that's not afraid to answer. Even if you're wrong, it's okay. This is our classroom. Who wants to take a stab at it? Jay, I'm going to go on for you.
Well,
It's
I would
okay.
say, I would say C, to swallow.
Okay. Carnegie, where you at? No, not Carnegie. Got a pretty name. Remind me of your first name, I know it. Yeah. Pointer. It's a pretty name, I know, I like it. You got the prettiest handwriting in the world. And I need to borrow one of your critical points. Remind me to address that later, okay? As an student example, they're very well done. You're welcome.
I would say,
Okay, so let's refresh some concepts that might help us better answer this. The purpose of the cuff is to maintain what? Positive pressure. However, it also prevents any air from otherwise entering, correct? So if I were to plug the opening to the trach, understanding that even if the patient breathes in, it's not going to pass the cuff. Now, which one's that correct answer? Deflate the cuff. Think about it this way, guys. If you were to take a cuffed trach, and the only way air is getting through to those lungs is through this opening, because even if they breathe in, it's not, this is it. Now the cuff, it's got to go through that hole. If I were to plug it and this cuff is inflated, are they able to move any air?
no.
Okay. See? Okay. So we want to deflate that cuff so that we permit that passage of air through. And y'all understand that? Like even if a patient's got an ET tube and an endotracheal tube, if they were to try to breathe through their nose, it's going to go down. It's going to follow its passageway, but that's it. Remember, these two join. Okay. So I did that on purpose just to kind of make you think through your questions there. Okay. Suctioning. When do we suction patients on the ventilator or with a trach? Okay, when I need to, in other words. We don't just arbitrarily go suction every 2 hours randomly just because. Why do we not have a standard of every hour, every 2 hours they have to be suctioned, period end? What, each time we suction, we can increase trauma, tissue trauma. So we suction when necessary. Josh just gave one incidence when their sats drop. What's another time that I might need to suction a patient who's receiving positive pressure ventilation? I see secretions in the ET tube or in the trach. Okay? So I've got a clinical reason to suction. I don't just randomly suction just because. Because I know that every time we suction, there's that potential for tissue trauma. Okay? We talked about ventilator-acquired pneumonia, and how we're gonna help prevent that. So what role do these two have? They're gonna prevent the buildup of hydrogen ions, which increases gastric secretions, which increases the likelihood for aspiration. Also, if you remember back to your practice assessment, this was one of those answers I gave you because I knew you had not had the content. People who receive positive pressure ventilation are at high risk for developing what? Stress ulcers. Now, we're not talking about psychological stress. We're talking about physiological stress. Okay, remember that's one of the complications associated with long-term mechanical ventilation. Okay, so NG tubes help maintain removal of secretions, things to dilate the bronchial tree, etc. Okay, when do we intubate somebody? Most commonly in respiratory failure, or for they're about to have a general anesthesia, and they're not going to be able to maintain or protect their own airway. Okay. Now we can do it prophylactically. You remember my conversation about the lady that mixed all her pool chemicals because she didn't want to keep paying her pool person? Okay? She thought she'd go out there and concoct her own chemicals to clean her pool, and all of a sudden she developed this enormous gas cloud that she didn't have time to step back from, and she inhaled that gas. Now what's going to happen to her mucosa? That's a burn, chemical burn. It's going to swell. So prophylactic. Let's not wait till it swells. You know, it's like, you know, if you get a bee sting on your finger, you don't wait till it swells to try to get your ring off. Right? You're like, let's get that off now, prophylactically. So respiratory failure, inhaled gas exchange, pretty much the same thing. Okay. One may still have the ventilation part working, but their gas exchange is very, very poor. And then we have those that they're so exhausted they can't maintain it anymore. Okay? So these are the people that need intubated. Okay, so we're going to focus on some of these settings. Some of these settings I'm not going to focus on because you're not a respiratory therapist, but you got the definitions here so that you know. But I do want to focus on tidal volume. So tidal volume is ballpark at 6 to 8 milliliters per kilogram of body weight. 6 to 8 mils per kilogram of body weight. It used to be 10, not that many years ago, but we found that that was having a negative consequence on cardiovascular function, so we're going to get to that. But 6 to 8 milliliters per kilogram body weight. So if you've got a little tiny frame person in there, then it would make sense that you don't have a high tidal volume setting on your ventilator. And then your larger patients, you're going to see those higher tidal volumes, okay? These others here, they're exactly what they say. You as a nurse aren't going to be having to measure that necessarily. You're going to look at it. You're going to look at your patient's actuals on your ventilator. But you're not going to be tested on that. Neither is NCLEX going to test you on that. Okay? Tidal volume, yeah, you're going to see that. But the rest of these, if you just look at the definition, it actually tells you what it is, right? And if you're doing pulmonary functions test on a patient, these are some of the things that they're going to examine on pulmonary functions test. Don't worry about this. I just want you to understand the origins of a ventilator. The first ventilators in this country were negative pressure devices, and we still have a few left in the United States, last time I did my research. So negative pressure ventilators were used for people, for instance, who had like muscular dystrophy, okay? And during their evening hours, they were unable to, or during their sleeping time, they were unable to maintain the negative pressure because of musculoskeletal problems. So what this device would do, the patient would go in their tube, their head would stay outside the tube, and it would gently, during the expiratory phase, bear down on the patient's chest, okay? So that when it let go, it acts like a vacuum. You see that? Negative pressure. If I were to push down, don't do it. But if you were, and you let go, it creates that negative pressure. Now that's sucking action, or sucking area, and it enables your patient to maintain ventilation even during their hours of sleep or when they were fatigued. So there's still a few of those apparatuses around. Old-fashioned term was iron lung, okay? We today use positive pressure ventilators. So we are actually blowing things in, okay? Again, your patient who does not have an intact respiratory drive, this isn't going to work for them. It's kind of like the same philosophy that if your patient's not breathing, you can blow all the oxygen you want up those nares, it's not going anywhere, right? You can put a mask on them. You can put 100% non-rebreather, but if they're not breathing, it's not doing anything. How many y'all remember Module C, SIM, your subdural? How many of you guys, you don't have to raise your hand, how many of y'all want to put nasal cannula or a mask on that patient?
I did.
Oh, see, Jay, I love it.
I did.
But that's why we do that SIM, on purpose, to give you that ability to say, oh my gosh, I can see now why we would have to maintain a positive pressure ventilation system for a patient who is either apneic or not maintaining an adequate respiratory rate or gas exchange. Okay, so for this type of system would never work for a patient who didn't have that. Okay, it would have to be positive pressure ventilation in that case. Okay, thank you, Jay. I love it. All right, so positive pressure ventilation. We've got time, volume, and pressure control. So far, my group that finished up already, you guys saw both the time and the volume. You saw the pressure and the volume. Time control you don't see as often. Okay, you also got to see an SIMV if I'm not mistaken. Didn't you, right, ladies? Okay. So we're going to talk about these different modes and what do they mean and what are they doing for my patient. And it doesn't matter what they look like. You guys, when you get like I was telling you before, when you get a different car or you get a different phone or a different type of laptop, you know it's going to have certain features, right? And you have an idea of where to locate them. You know your radio in your car is not going to be located in the back seat. It's going to be somewhere tangible where safely you can access it. If it's not on your steering wheel, it's going to be on your column or both. But you know that it's going to be somewhere. You know your windshield wipers are going to be around that steering wheel. So you know where to look for them and have a good idea of what it's going to look like. So it doesn't matter what model ventilator you see. When you know what you're looking for, you're going to be able to find your settings. Okay? We don't teach equipment because equipment changes. It can change to, we had a brand new fangled thing on the A-line yesterday I've not seen yet. Well, when did I get here? I'm only here twice a week. Okay? So it's okay. The things change, and that's normal, but NCLEX isn't testing you on a device. They're testing you on what is this device doing for your patient. Do you know how to evaluate that it's working or not working? So this is some things we're going to spend some time on. In a nutshell, controlled, if there was a true, completely controlled patient, which you're not going to see, CMV, it controls every single aspect of the patient's ventilatory cycle and will not permit any spontaneous activity on the patient's behalf, okay? But we're going to focus on the two that you're going to see most commonly, assist control, SIMV. So assist control, Janaea or Chloe, do you ladies or Quan, would you like to explain, based on what you recall, what assist control means? What is it doing for my patient?
Maintaining the amount of volume inside.
Or, if it's not controlling for volume, it's controlling pressure. And okay. Can my patient completely rest and the machine will do everything?
Yes,
You
it
can with
if
assist
it
control.
detects it, yes.
That's true with assist control. In other words, we call assist control the resting mode. If your patient is incapable of maintaining their rate or their volume or their pressure, it's got it all covered, everything. But what does it have the ability to detect, Chloe?
It can detect like if they're spontaneously breathing.
Very good. It will detect a patient's ability to trigger their own breath. Now, when they trigger their own breath, Chloe, is it still going to control something?
Mm-hmm. It'll still control either volume or pressure.
Very good. So what you're going to see on your device is AC, and then you're going to see either PC or VC nearby. And so what that's telling you is it's either going to control volume or pressure with that breath. So even with the breaths the patient triggers, in other words, the device detects that little bit of negative pressure change. Like, wait, what's that? It's like, okay, get your bad self. You try, but I'm controlling your volume or your pressure. Because while you may be gaining control of your rate or your intrinsic drive to trigger a breath, you're not going to be able to achieve the volume or pressure I want you to get with that breath. So it's going to allow that patient to trigger that spontaneous breath, but it's still going to control something, either the volume or the pressure, and that will be on your device, either with a PC or a VC. But if the patient is unable to maintain any spontaneous respirations at all, it's like, okay, I got that too. And that's where you see your rate, noted by the small f for frequency. In other words, if it's a f of 15 or 16, that means no matter what, this patient's gonna get a minimum of 16 breaths per minute. They're mandatory breaths, they must have these because I said so. Okay? Whereas SIMV, who saw my SIMV? We had a couple. Oh, Judea, look at, did you see Chloe do that? She's like, threw her under the bus. She owes you lunch. Okay, Junea, how did SIMV differ from AC?
It let them control the rate and then the volume.
Very good. Okay, so synchronized mandatory ventilation. So what we have here is we still have that minimum number of breaths per minute the patient's going to have to achieve. They call this as a type of weaning mode, even though it's not used clinically that way. But it's considered a weaning mode because what it does is it provides the patient more autonomy. It will synchronize with the patient's own triggered breaths, and it will also allow them to determine their rate or their volume with that breath. Now the breaths that it gives, it controls all that. So you see how it's more of a weaning mode? It's like not only detecting the patient, synchronizing with the patient's triggered breaths, but it allows them a little more autonomy over that volume or that pressure. It's like, okay, let's see how you do with that. Okay? Everybody good so far? So there's so much more in this discussion, but we're not going to do that. Okay? You're not taking a respiratory therapy test. Yes? Here.
So like, if they're meeting the number of breaths, but they don't meet the volume, how does that work with it?
Okay, you'll see that. You'll start seeing
So a
evidence
little alarm
of,
and then you'll go to AC?
that's right.
Okay.
You'll see that your patient's not meeting what the device would like to see associated with that breath, and we'll switch settings. That's exactly right.
That happened to my patient last time I was in clinic.
Uh-huh.
Right.
Uh-huh. Sure did.
Yeah.
See, that's why I love my clinicals. I love ICU clinicals because what we talk about in class, except the burn patient, you're gonna see it. Okay? Jay, why didn't you had that septic shock patient yesterday? Classic septic shock. Okay? When you're, and I love it, not for the patient's sake, I'm not being morbid over here. I'm just saying that it's good because it helps you link your learning outcomes to what you're seeing in the clinical setting. Okay? So we're okay here. Pressure support. Now this is a different setting. I know Quan saw it, I know Jay saw it, and I think one of you two ladies saw it as well. So on the ventilator now, I've got a mode. Jay, I know you did that last week, I'm almost positive. And they didn't tolerate it. So on your ventilator setting, you're going to see a big S, which stands for spontaneous. Because what's happening now is we have changed our vent settings to where the patient controls the rate. So we are truly in the weaning mode at this point. Pressure support means exactly what it says. All we're going to do is support this patient with some pressure, some positive pressure. Because they're in control of their rate now, and we're going to see how they do. Jay, your patient did something which is atypical. Quan, your patient did the typical, if I remember correctly. Jay, do you remember your patient with the pressure support? That's right, they went apneic, which is not typically what you see. Now, that's a problem, right? So your job, when your patient's transitioned over, so you're not going to see a minimum number of breaths per minute on your device. You won't see that frequency anymore because there isn't anything, okay? The patient's controlling their rate. We're just supporting them with a little bit of pressure, so positive pressure to dwell in that chest cavity. And we're going to watch them and see how they do. Okay, so it's kind of like putting your pacemaker on standby. If I take a temporary pacemaker and I don't disconnect it, I'm going to put it on standby, and we're going to watch that intrinsic rhythm and see what happens. See if we can achieve adequate cardiac output. Is the rate sustainable for cardiac output? And so with this, we're looking at, is my patient going to be able to transition off his ventilator? So we're going to look for things like apnea, which isn't as common. Right, well that's probably not going to work today. That'd be like turning off your pacemaker and putting it on standby, and all of a sudden you see third-degree heart block. Well, probably need to connect. Now, let's turn that back on. More commonly, you'll see patients like Quan's patient who starts displaying signs that they're not tolerating this weaning attempt, as evidenced by what, Quan? Do you remember? What happens to their respiratory rate? So we have tachycardia, tachypnea, hypertension, diaphoresis, panic look, increased work of breathing, nasal flaring, accessory muscle use, the work. In other words, they look like me on a Stairmaster. Now, back in the day, I could rock a Stairmaster. Not today. Okay.
I think my patient went up to like 160
Yes.
within a minute.
Within a minute. Did y'all hear that? Okay, so Quan, that gave him the ability to realize too that this is an assessment. You've got to be, you guys, you don't walk out your patient's room when they've had a change to their ventilator stage, regardless of what we changed. Monitor your patient's response. Imagine how scared you would be if you can't speak, you're restrained, so you can't bang the side rails like you want to, can't get up out of the bed and go to the nurse station and say, hello. But you're terrified because you can't do this. Quan, what was the number one reason for failure to wean? Inadequate what? Food, nutrition. Inadequate nutrition. The diaphragm becomes very weak. You know, we don't realize how hard it is to breathe. We don't realize how much work is associated with breathing. It's a lot. And these patients don't wean successfully often because they're just too weak to. And failure to institute nutrition within the first 24 or 48 hours is paramount. Okay, it's one of your primary reasons for they're just too weak. Okay, so we look at that physiological response. We look for the tachycardia, the tachypnea, the hypertension, the diaphoresis. We look for that accessory muscle use. Some of you, one of my ladies, I know, ladies, one of you guys in the last clinical group, you saw that too. Who was that? Y'all remember the belly was just a moving? Wasn't that one of you too? That, I mean, they were doing that gulpy breathing like we talk. You know, you look for, and by the way, what are signs of central cyanosis? Wait a minute, who was it yesterday? Who was it yesterday?
It was Winter.
Winter's not here. Classic central cyanosis signs. What are signs and symptoms of central cyanosis? Blue around circumoral, we call it circumoral cyanosis. And if there was ever circumoral cyanosis, it was classic yesterday. Circumoral cyanosis, cyanosis around the nares and the earlobes. You know, my fingernails can turn like blue when I'm cold. That's just peripheral shunting. But this doesn't turn blue unless you're hypoxic. Okay? So we look for those signs and symptoms. How would I know my patient is simply working too hard or not maintaining a rate compatible with life? Because that's my job, to monitor that response and not walk out that door. Okay? So that we know. Don't worry about these two. They're exactly what they say they are, but whatever. All right. So another form of positive pressure ventilation is a CPAP and a BiPAP, but what must your patient have intact? That's right, a drive. If their brain is not working, this isn't going to work either. Okay? They must have that ability to maintain that negative pressure. Because although it's positive pressure we're blowing in, they have to be able to pull it in. Okay? So CPAP, what kind of patient gets a CPAP? Sleep apnea patient. We know who's at the highest risk for sleep apnea. Increased BMI, etc. Okay? We know what happens with that is the soft palate tissues collapse because as we increase our BMI, it's not selective to certain parts of the body. It increases tissues everywhere. Like people can lose weight and need different dentures. Okay? Because all of your structures will lose body mass. So all we're doing is forcing air into that oral airway to keep these soft tissue structures from collapsing. That's all we're doing. It doesn't adjust for whether the patient's in the inspiratory or expiratory phase. It's continuous. So there's a constant airway pressure, and that's the purpose of it. It doesn't have oxygen with it, and the patient has to have a neurologically intact brain and the ability to breathe. Whereas BiPAP has a little bit of a different feature here now. What's different about, there's two primary things that are different with BiPAP as compared to CPAP. What are they? Bi, what does that tell you? Bi-level. Two different pressures. So there's an inspiratory pressure and an expiratory pressure. Typically the inspiratory pressure is higher than the expiratory pressure. They're both going to be blowing in. They'll both be positive, but it'll allow for that expiratory phase to exhale some too, as opposed to blowing against it. Does that make sense? So you'll have an IPAP and an EPAP. Your IPAP's 10-ish, EPAP 8-ish is usually a ballpark you'll see, centimeters of pressure. And it also has another element we add to that, oxygen. Okay, so with BiPAP we can actually provide oxygen. All right, so settings on my vent that I want to concentrate on. the rate, and noted by a small s for frequency. What is the minimum number of mandatory breaths per minute this device is going to make sure this patient has received? Remember, with pressure support, you're not going to see that. There is a fail-safe backup should the patient go completely apneic and you're in a code in another room. It won't just say, oh, too bad for you. It will kick in and say, okay, we have a problem, okay? So there is that fail-safe kind of built-in protective mechanism, but you're not going to see it on your settings. Tidal volume, I've already talked about 6 to 8 milliliters per kilogram of body weight. Your FiO2, just think of this as another way that we're delivering oxygen directly down the trachea. When you're at 100% FiO2, we don't have a whole lot more to offer. Okay, we're kind of at the end of our road. Your inspiratory to expiratory ratio, Jessica, what does that mean? What's a normal inspiratory to expiratory ratio, and what does that mean? 1 to 2 is a normal.
Expiratory rate should be double.
That's right. It takes about twice as long to exhale as it does to inhale. So you're looking at your IE ratio on your ventilator, and you're looking for a ballpark of 1 to 2. Inspiratory peak flow rate is exactly what it says it is. Do not worry about it. Sensitivity, okay, we're going to visit that in just a minute. Size or periods of hyperventilation, like if we need to hyperventilate the patient quickly when their stats have really plummeted or whatever, we can do that. Pressure limits, I'm going to get back to with sensitivity, and then PEEP, positive end expiratory pressure. At the end of the expiratory phase, the device is ensuring that there's still positive pressure dwelling in there, because what's that going to do to the alveoli? It's going to maximize the duration of expansion so that we can maximize gas exchange time. The people who need PEEP are people who have poor surfactant production, like your ARDS patients, your compliance patients like your COPD. I don't mean compliance with medical regime, I mean chest compliance patients. So the risks, however, associated with PEEP are that we can rupture these two things I told you to look up last week. So who did it? Hollis, what were blebs or bullae?
I was again.
Oh, she got it. Okay, last you were. What was the bleb or bullae?
I know when we were talking about the tracheal deviation, you said something about bleb, or it was like a flash.
Okay, what is a bleb though? Tyler, what's a bleb or a bullae? It's okay, you can phone a friend. Oh, Jessica, she phoned you. See how that works?
So whenever I looked it up,
Good job.
it said a small collection of air between the lung and the outer surface of the lung.
It's like a little sac. Very good, keep going.
Usually it's found in the upper lobe of the lung, and when the bleb is ruptured, the air escapes into the chest cavity, causing a pneumothorax,
Booyah.
which can result in a collapsed lung.
Awesome. Blebs or bullae, you can Google them and look at pictures of them. They're little pouches. Not to equate the lungs with the colon, but what are the little pouches on the colon that can develop as a consequence of low fiber diets? What are those things called? Diverticuli. Now, diverticuli by themselves are harmless, right? It's not until they get inflamed or infected or they perforate that we have a problem. What causes them? Sustained high pressures in the colon due to poor diet. Too much cheese, not enough broccoli. Okay? Those sustained high pressures eventually weaken the colonic wall and they cause the diverticuli. In the pulmonary system, the same consequence. You've got people who have chronic sustained high pressures can be predisposed to the development of these blebs or bullae. Problem is when we add things like positive pressure ventilation as it's in its own, and or add PEEP, which is ensuring more positive pressures dwelling in there, we can cause them to perforate. So 5 to 15 centimeters is a ballpark PEEP range. My job as a nurse, number one, just having the patient mechanically ventilated, receiving positive pressure ventilation. But number two, has a higher amount of PEEP, is to monitor for signs and symptoms of a pneumothorax. Because I know, again, remember, what sets you apart as an RN is your ability not just to collect the data, but to analyze it. Who is at risk for what? Therefore, now I know what measures to implement to protect them. So while we're on that, let's build off of that and go to these pressure limits and sensitivity. You remember on your pacemaker, you guys, it had to be sensitive enough to detect intrinsic rhythm, right? I mean, I don't want the pacemaker taking over when my patient's rhythm is working normally. I need it to be sensitive enough to know when to step back and say, okay, you got this. I'm gonna be here just in case. So, same thing with the ventilator. I need that sensitivity intact to detect those triggers of those breaths. I need it to know when my patient is trying to get better. They're trying to assist their ventilator. But, okay, I want you to use some critical thinking. Jade, your patient yesterday was on a paralytic. Would it be reasonable to assume he will have any spontaneous respiratory activity? No. He's paralyzed. Don't look for it then. What about Tyler? If they're on a lot of propofol, would it be reasonable for me to look for spontaneous respirations? With propofol? Not when they're high, not when the propofol rates are high, because what do propofol suppress? Respiratory drive. That's why dexmedetomidine is better for a patient we're trying to wean. Because dex doesn't have that respiratory depressant effect. And yet if they're still really, really anxious, we would put them on the dexmedetomidine and kind of ease them through the transition without having the respiratory depressant effect. Now remember, propofol is a Michael Jackson drug. Okay? It tells you just very how much out of line the prescriber was. You're prescribing an IV medication that requires mechanical ventilation to a person in their home. I'm glad he lost his license. Shame on him. Right? Y'all know what I'm talking about? Okay. Y'all look at me like, I'm like, I'm not that. Michael Jackson's not old. I tell you about there's an airplane dog, like I was from Mars. I'm like, there's an airplane dog. That's the 60s and 70s. Not that old. Okay. Pressure limits. So here again, going along with that sensitivity, going along with the monitoring for pneumothorax, I also need to be really mindful of listening out for my alarms. So I've got two different types of alarms. And I know Sydney's already prepared because I can see her. She's got those notes. She's ready to go. So Sydney, what might be some circumstances in which a patient's alarm, high pressure alarm, is going to go off? And what does that mean?
That it's meeting a lot of resistance.
Okay. Okay, stop right there. Excellent. When your high pressure alarm goes off on your vent, it's trying to tell you, whoa, this is too hard. Shouldn't be this hard. I know I'm anticipating a certain amount of resistance because I'm blowing into the thoracic cavity and there's structures in there, so I anticipate some barriers, but this is a lot of pressure. Excellent. So what are some situations that would cause us to have greater pressures in here than the vent is anticipating?
When they bite down on the
Excellent. So the tube's been kinked for some reason or another. They're having a seizure and they fit down the ET tube. The tube's become kinked. Somebody's at the bedside standing on the tube. What else? The vent tubing. What else?
pneumothorax.
A pneumothorax. Cough. Good job, Hollis. A cough. Isn't that going to produce counter pressure? Okay, a pneumothorax. If that little lung's wad up in a little ball, it's not going to be able to positive pressure ventilate that. Okay? So high pressure alarms you don't ignore. What about a mucus plug? Could that be a cause of a high pressure alarm? Mm-hmm. Sure could. Okay? So, Pierce, I know you have prepared. Low pressure alarm means what? First start with that. What does that mean?
It's not meeting enough resistance.
It's not meeting what it anticipated on resistance. It's like, okay, dude, I can do this all day long. This is easy peasy. I don't know what's going on, but I'm meeting very little resistance, not what I expected to meet. What are some potential causes of a low pressure alarm?
Any disconnection in the tube.
That makes sense, doesn't it? If your ET tube has become disconnected and it's just blowing the atmosphere, it's like, I can do this all day. Y'all gonna pay me for this? This is easy. Okay? Now, we have patients that are extubated themselves or our apparatus has become disconnected at some point along the tubing. What is your, okay, so I'm not waiting long to figure this out. I'm walking towards the room as I'm assessing the environment. What's going on? Why is my low pressure alarm going off? Because what is my priority action if I can't quickly discern that, yep, we have extubated ourselves, or yep, tubing's disconnected. What's my priority back? What do I need to do?
Make sure they're getting oxygen.
Okay, and how are you going to do that?
Backbone.
That's right, you're going to bag your patient. Because you probably at this point have a device failure. Okay, something's not working right somewhere. And we can't sit there and dawdle about it. Okay, this actually happened a few years back. It was with one of my former students, a new nurse who had transitioned from the ER up to the unit, and the patient's wife was at the bedside. and we hear the low pressure alarm go off. So we're walking towards my former student who was the primary oriented, went towards the room, and I'm trying to be calm because the wife is right here. Okay, we don't want to excite families, that's not fair. They're scared already. Can't quickly discern. I said, we need to bag the patient. Monotone, flat. The new ER nurse was, well, no, I think it's such and such and such and such. We need to bag the patient. Finally, my other little graduate's like, we need to bag the patient. Yeah, let's do that. And it was. The vent had failed. Okay? The key here is we can't let that go on. We've got to act quickly. Bag your patient. By the way, now you're, again, on the inside, your adrenaline may be running. On the outside, we can't see that, right? So on the outside, you're not going with your ambu bag. Right? You remember? No. A minimum rate on a ventilator is 10 breaths per minute. Think about that. So about every 6 seconds is what we need. Okay? Let's maintain calmness. The wife didn't have to get all upset or excited. She knew something was going on, but it was under control. We got this. And they just gently explained to her, yeah, I think our machines might have something going on with it. We're going to switch it out. So we bagged the patient till the other vent got it fixed. Okay? All right. So let's see. I think that's most of your settings. I want to make sure I leave Mr. Money time to do his thing, give you guys a break. Where am I at? 35. Okay. So complications. I'm not going to focus on everything here. Whenever I increase pressure in the body, we know from Module C, we're increasing intracranial pressure potentially, correct? I already talked about gastrointestinal complications. I already talked about respiratory. Infection goes along with that. There can be this thing called ventilator dependence, and it has a physical and psychological element to that. It's very scary when you've been passively breathing through positive pressure ventilation, to suddenly have to sustain your own, and you don't realize how scary that is when you're weak. Okay? Now, cardiovascular is one thing I said I was going to get to. It's on the same lines of that hemothorax. You've got increasing volume in the chest cavity, which is going to decrease the ability of venous return to occur. Nobody's walking around with pulmonary functions tests. Okay? I mean, my husband does, but I haven't had PFVs. I have no idea what my real tidal volume is. So we estimate 6 to 8 mils per kilogram body weight. However, that patient may not tolerate that, because the more volume I put in here, the more likely I'm impeding venous return. And what am I going to see? Hypotension. Same thing with PEEP. It can do the same thing. So we added PEEP. We went from 5 to 8 centimeters of pressure, and all of a sudden we see that blood pressure start dropping down. Like, what? Probably need to back off on the PEEP and look for that cardiovascular response to return. Okay? Because again, everything's got to have room to do its job. Also, that increased pressure can cause problems with the GI tract, and actually can promote an ileus, because again, it's got to have space. It needs to be able to do its job. And if I've increased this volume in here, I've kept it from being able to do that. Weaning. Okay, extubation. It makes sense that if you're about to disconnect a patient from the ventilator, that we need to be ready for emergent re-intubation, because this may not go well. And one of the signs we listen to, if you remember from your practice assessment, was stridor. Do we hear stridor? We got tight airway. We need to do something about that. Or a patient who really doesn't tolerate that extubation attempt well, and they were doing great during the weaning attempt, but now they're really fatigued. They're not handling that well. Okay. Just like if you're about to remove a Foley from a patient who's non-ambulatory, don't we need to have a plan B? I mean, they're still going to pee. So we need to have a urinal at bedside, or a bedside commode, or a pan, or something, right? We're going to follow through with what we need to do. Just because we disconnected this doesn't mean there's not a follow through. So nobody goes from FiO2 to room air. Do we need a mask? Do we need a trach collar? What do we need? Do we need high flow O2? Do we need nasal cannula? We'll give you all a break after this before spring starts. So we have a radical neck dissection. What am I worried about? Airway, right? So which one is it? Stridor. That's right, A. The trachea is shifting towards the left, which tells me the right has greater pressure. Okay? And they're on the ventilator and I have a high pressure alarm going. Now, I want to talk about some things here. Paradoxical, remember, is different from symmetrical, right? You'll understand the difference there. Also, I want to talk about this patient right here. Is the ventilator going to save this patient's life, yes or no?
No.
No, because we have a that's right, Juan, we have a vascular problem here. And we can do all we want with that ventilator, it's not going to save this patient's life. That doesn't mean that we won't intubate them, don't get me wrong, but that's not going to fix the problem. And they can still die until we restore perfusion. Okay? All right. Before I give you a break, any questions? All right, if you, something comes up and you have some questions, let me know, just email me or whatever. And go ahead and break until 9:30. Now y'all please, don't be coming in here like you did this morning. All right? Y'all hadn't done that all semester. So go take your break and be in here at 9:30 sharp.